All right, good afternoon, ladies and gentlemen, and welcome. We're here for our Opioid Town Hall. We've been waiting for this event to take place for a number of weeks here. It is finally here. So we are here with my colleague from WPVI, Trish Hartman. Hi there, and we're going to be here for a little bit talking to you as we prepare to set up for this event. It's going to be starting in about 15 minutes from now. We're going to go up to the stage and you'll hear from our anchor, WABC anchor Liz Cho. She will open the show coming up in just a short period of time. But we do have the opportunity to talk to some of the guests that are out here. Trish, is there anything you want to tell the folks as we get ready to start this whole thing?
Well, we've been getting ready for this event for a number of weeks. It's really been a great chance to team up with our friends at Channel 7 Eyewitness News here with WPVI in Philadelphia, and it's been a chance to really cover the opioid crisis in New Jersey and throughout our area in a really comprehensive way. Anthony, I know you've done some reporting, and I have as well, meeting some people that have really been affected by this crisis, people who have lost loved ones, people in recovery, people who are taking that next step, and we have some interviews lined up for us here just to give us a sneak preview of what we're going to hear in this town hall that starts at 4 o'clock.
And start out with Eric McIntyre. Now this guy right here, you are part of a team that works here at RWJ that goes out and tries to help people that are opioid addicted. You guys have done a fantastic job, innovative and creative ways to try to deal with this problem. But I think we should set this up by talking about the issue that you dealt with yourself. When you go and talk to people that have this problem, you're not talking as somebody that doesn't know it. You know it personally. Tell
Correct.
us about
Well,
that.
all of us, myself included, and all of the recovery specialists, they're in recovery themselves, at least 4 years in recovery. So one thing we take off the table right off the bat, if somebody's sick and suffering from SUD in the bedside, we're taking off the table saying, you have no idea what I'm going through. You don't understand. That's when we get to say, no, I understand exactly what you're going through. And there's a way out. We could talk about our way out. We could find out what their wants and needs are. But the main thing is just being an ear to listen, a shoulder to lean on, and making a friend as we come in there. So we're not coming in there offering one way of treatment, trying to convince them to go to one place, one path. There's multiple pathways to recovery. So we want to make a friend, find out what their wants and needs are. If they choose to change their way of living, we have navigators to provide a clinical assessment. And, we're getting a lot of success stories out here.
And this is like in the emergency room. As soon as folks come in, no matter if they complain about, I came in with a stomach ache, you take a second assessment just to make sure what's going on there, right?
Yeah, correct. Somebody come in with abdominal pains. They might be in withdrawal from opioid abuse. They don't know that, Well, the doctors don't know that, the nurse don't know that, but now they're looking at that and taking a look at it. And if they suspect it, we'll get, they'll tell us about it. We get it's called Tiger Connect. So we get a text saying, go to this bed. And that's why we don't walk in being like accusing the individual of having an addiction or anything like that. That's why I always say we're going in there making a friend. And once you're friends with somebody, you find out what their wants and needs are. And if they understand they want some help, we're going to help them. It doesn't matter about their insurance, lack thereof, finances. Everybody gets the help, which is wonderful.
Eric, you know what these people are going through. Can you talk a little bit about your personal story and kind of how it started for you?
Yeah, well, live TV. No, I'm joking. I'm in recovery a little over 16 years, and prior to that 16 years, unfortunately, I was totally addicted to heroin, crack, pretty much anything I got my hands on. But I lived such a foul life, and, I was in and out of jail. I had zero hope. I never thought I'd get out of it. My best idea was just how could I get through the day. And fast forward where I am now. I'm married. I have 3 beautiful children. I'm the assistant director to this program, and it wasn't an easy path, and I certainly wouldn't direct the same path that I went through to somebody else, because what got me into recovery may hurt somebody else. That's why all I needed was somebody to help guide me through the whole thing. Let me fall when I needed to fall, but help pick me up when I need to be picked up. You need to be in recovery, you need to socialize with people. You can't just be hidden somewhere. And that's what we do. We're like all of our recovery specialists, we're outgoing. We're going to go laugh, joke with them. We'll meet them at meetings. We have all recovery meetings in all of our hospitals. All recovery meetings are the best thing. Absolutely, anybody's welcome. You could be still active, struggling, on medicated-assisted treatment, abstinent-based, friend, family member, anybody's welcome. It's just a peer-led group trying to lift one another up.
And when did you hit rock bottom, if you don't mind me asking?
I hit rock bottom pretty much on a weekly basis out there. When you're doing crack and heroin, there's really no top bottom. The finances are gone. I lost my wife. I had nowhere to go. I was an only child. Single parent mom was taking care of me. I burnt that bridge. just had nowhere to go. So, you know, when you find the different recovery rooms, they're basically the last house on the block. But the thing is, even if you mess up in there, they always let you back in. So you just keep trying. I never gave up. You know, my personal path is 12-step abstinent-based, but that's not everybody's path, and I totally respect any path to recovery.
We're going to talk about so many different issues tonight regarding substance use. What do you think is the biggest barrier for someone who is dealing with a substance use disorder, blocking them from getting treatment? What do you think is the biggest barrier?
It's not one thing. I mean, there's a lot of barriers. It used to be all of us were screaming, there's no beds, there's no beds. Sometimes somebody doesn't qualify to have a bed, you know, which is usually inpatient detox. I mean, they have the MAT now. Everything's based on a clinical assessment. I'm not a doctor, so I can't say what somebody needs. But for somebody to be suffering at this moment, they think that they can't go to the next level. They don't see themselves successful. That's why we got to be their cheerleaders, you know. It's not shaming them, oh, you did this to yourself, what's the matter with you? We got to constantly build somebody up. It's small little milestones, you know. You just set little goals at a time, and if we follow them through, they're going to, you know, feel a little self-worth, a little more and more each time. And people come out of it. I mean, nobody knows me 16 years ago, but it don't make no sense that I'm here talking to you people.
And you're looking good, too.
I was gonna say, what is it like for you to be doing this work now?
The best thing in the world. Prior to this, I did union construction in Manhattan, which I loved, and I made good money. But this is so rewarding because you could see somebody at bedside, they're distraught, they have zero hope, you think, but they're having a conversation with you. You know, there's nobody else there, so they're just talking to you. And when you see that person get well, and now all of a sudden they're doing good, they start getting their family back, their friends back, new friends, a job, you know, it's the most amazing thing. It's so rewarding. There's nothing better than it.
You know, what's so interesting to me, you were talking about this before we even went on the air, but today you don't wait for folks to hit bottom. And why is that you don't wait that long anymore?
Because like I told you earlier, I said it used to be you got to hit bottom before you could accept the help, and you got to want it. I said that's true, and you get a good foundation like that, but bottom's here, but death is a little bit higher. So on the way down with addiction, they're dying before they hit the bottom that we were talking about. So we got to intervene, try to get you know, involved in their life, and just say, listen, we're here for you. We can help you in many ways. You know, all you got to do is just give us the phone number, say yes, say hello, and we'll, you know, walk a mile in their shoes with them. They don't have to do it alone.
And you were telling me that this program at Robert Wood Johnson has expanded greatly in the past couple of years. You said you started out as a per diem counselor. Now it's expanded into multiple counties.
We started about 6 or 7 of us were doing per diems. And now there's about 100 recovery specialists. They're all full-time staff members for the hospital system, you know, Institute for Prevention and Recovery, and we are actually based in each hospital. So here at Robert Wood Johnson, New Brunswick, we have 6 full-time recovery specialists doing magic on a daily basis.
On a daily basis?
Yep.
They're coming
24/7.
Really? And
Yep.
if somebody calls you on a weekend, if somebody calls you in the middle of the night?
7 days a week, 24 hours a day. There's no holidays. Addiction doesn't take a day off, so neither do we.
Thank you so much.
Thank you for
Thank
sharing
you.
your story.
Have a good
Being
one.
here, yes,
Thank
indeed.
you, Eric.
All right.
Thank
Bye-bye.
you so
And
much.
so you can see, thank you very much, Eric. You can see behind us, Trista, it looks like the room is starting to really fill up. And in just a few minutes from now, we'll be getting the program underway. It's going to be here until 6 o'clock. So folks have signed up. I understand over 200 folks have signed up for this.
Yeah, it's really exciting to see people coming in. I was talking with some folks who are here, and they've been watching our stories leading up to this, and it seems like everybody knows someone who was affected by this. And I know that you've met some people too over the past couple of weeks who, you know, opioid addiction has played a massive role in their lives.
Well, interestingly enough, the young lady that I interviewed is here, Amanda, and her story was really fascinating because she came along as an only child. Her mother was addicted basically to alcohol. So she was introduced to addiction early on, and she struggled with it throughout her life. Now she's in her 9th month of recovery. She had met another recovery specialist like Eric that we had talked to in the hospital, and they were really meeting every now and then. She'd be going into the hospital 2 or 3 times. The 3rd time she went into the hospital, guess what? she decided to call out to Al. Al walks up to her. They reestablished their relationship, and now she's in recovery. And she was a woman that was actually living on the steps of the library here in New Brunswick. That's how bad the situation had gotten for her. So there's so many of those stories.
We had a success story on our air this week as well. There's a young woman who was recently hired as an assistant prosecutor for Burlington County. She struggled with opioid addiction as a teen and was in and out of treatment centers. She has been in recovery for a number of years now. She went to law school after graduating from college, and she now prosecutes some drug cases. And it was really interesting to hear her perspective on how she does her job given her experience. But she says she doesn't take a single day for granted.
They normally don't. We're going to bring in another guest ready to go, the head of the recovery team here.
Hello. Come on in here. Stand right in between us. There we go. Tell us who you are and what you do.
Connie Green, Robert Wood Johnson, Barnabas Health. I'm the vice president for the Institute for Prevention and Recovery.
And what's it like to have this event finally be here? We've been working on this for a long time. What are you hoping comes out of tonight?
You know, as I walk around and I'm speaking to some of the people who are sitting here, having family members who are not yet in recovery and struggling with this disease, what I'm hoping is that people walk away understanding, I think, two very important things. One is that this stigma has interrupted the ability for people to get appropriate service because they don't know where to go. And it's a bottomless pit. When substance use disorder hits your family, people don't know how to access service. So the stigma has to change, and this has to be a disease that's compatible with every other disease, that you have high blood pressure, you have cholesterol, you have diabetes, and you need help. Everyone knows where you should go for help. With this disease, that bottomless pit just circles and circles with hopelessness. So I'm hoping today that people, number one, see this hope. There is recovery after the damaging shame and horrors of this disease, that recovery is possible, and that there are resources out there that exist, and we're hoping that people, maybe after they leave here today, have at least telephone numbers of reaching out and access to support within their community.
I know one of the subjects that we're going to cover here tonight is if you have a loved one who is dealing with an opioid issue. So many loved ones don't know what to do for their spouse, for their children, for their moms and dads.
Well, the problem with the disease is that the individual who is in the throes of addiction and the progression oftentimes doesn't want help in the moment that the family wants help. So that's one of the biggest issues, that you can't get help for someone who's not ready for the help. What RWJ Barnabas has as a service when someone comes into our hospital is recovery supports. And those are individuals who are in recovery and know how to reach out and to engage someone who feels hopeless, who feels worthless, to see that there's an answer. And that peer-to-peer connection is really important. Families are trying to do this on their own, and it's a disease that really has limitations and barriers for that.
And Connie, we had talked a couple of weeks ago, and you told us that once people come into the hospital and you start to identify the fact that they have an opioid problem, you just don't really let them walk out the hospital scot-free and never stay with them. What do you do?
Well, bedside comes the recovery care team, and that's the recovery specialist with our clinical navigators that are available to assess and move someone into the appropriate service area or the appropriate level of care. What's really important is that no one leaves this hospital unattended, so that recovery specialist continues to call them, continues to reach out to them, and as I often say, stalks them lovingly until that point that they are ready. And most people are not ready at bedside. Most people are ready 2 to 4 weeks later because someone's calling them every day and someone is reaching out and knows where they're at.
Okay, there you can hear they're getting ready to get started here in a couple of minutes here. Connie, so good to see you again. Thank you. Good to see you. Thank you so much. We really appreciate it. And Doctor, come on in. We have one more guest we do quickly with a couple of minutes left. How are you?
Nice meeting you guys.
Just introduce yourself.
So I'm Teresa Miskimen, and I am the Vice President for Medical Affairs over at Rutgers University Behavioral Health Care. We are so pleased that this is happening tonight. I think this is going to be a great opportunity for family, friends, the community to come together and be listening and hearing about something that will be crucial for a lot of people. How is it that we're going to be able to not only diagnose, but how is it that we're going to treat and be able to re-engage people in our communities? So I hope that you really enjoy this particular program tonight.
And how is treatment changing over the years? I know it's kind of evolved into something.
So at Rutgers University Behavioral Health Care, we actually provide the continuum of care, which means that we are not only diagnosing, that we are treating, and we are re-engaging people to get back into the community so that they can then be part of that again. I think that part of the opioid crisis is that it really has destroyed families and communities. And how is it that we're going to be going beyond the stigma? How is it that we're going to be empowering people so that they can actually come back and say, it's an illness, there's treatment, there are ways for me to get back on track and just go on and do what I need to do to get back into my community.
Excellent.
Teresa.
And we're available at University Behavioral Health Care. It's Access Center. If you want help and care, you can contact us 1-800-5839-6300, and you can always call, and we're here to help. Thank you so much. I appreciate the time.
I know that information is going to be out here all day and all afternoon long as we're here. They're going to continue to give you information about numbers that you can call, important information dealing with the crisis. But we're really getting ready to start this thing in just a few minutes from now. It's a pretty big crowd out here. Like I said, some 200 folks. Most of the place is already filled up. We're inside of the hospital auditorium. Looks like a good crowd, and a lot of important information is going to come out here this afternoon.
Absolutely. Your Liz Cho is here. Our anchor Rick Williams is here, as well as Dr. Jennifer Ashton from It's going to be a lot of resources for people to take away from this discussion. So we're hoping that it's going to be a really productive evening.
It looks like it's getting ready to start right now. Let's turn to my colleague, Liz Cho. She's getting ready to step up to the podium right now as we begin the program. The town hall on the opioid crisis is about to begin. Thanks for joining us, folks, and pay attention and listen on. We'll be on the whole afternoon.
For coming and joining us today. And welcome to our town hall hosted by New York's WABC, WPVI's Philadelphia, and our W.J. Barnabas Health Institute for Prevention and Recovery. I'm Liz Cho. I'm one of your moderators today from WABC, and I am joined by ABC News Chief Medical Correspondent Dr. Jen Ashton and Action News anchor Rick Williams. Thank you all so much for taking time out of your very busy days to come join this very important conversation. Our subject for the next 2 hours will be the opioid crisis, a national scourge that last year directly resulted in the deaths of more than 48,000 Americans, including more than 3,000 deaths here in New Jersey alone. Those numbers, they are staggering and represent the real and horrifying cost of the worst drug crisis in American history. Today, our panel of experts who are right here on the stage with me will delve deeper into the root causes that have taken such a grave toll on this country and the state of New Jersey as we focus on the dangerously addictive qualities that make opioids so very deadly and the treatment options available to the countless thousands in the abusive thrall of these drugs. It is abuse that I have learned firsthand. In March of this year, we learned that one of my husband's dear friends, Mark, he had an opioid addiction. In a series of long and brutal phone conversations with Mark's wife, we learned that Mark had admitted to pervasive opioid use that stretched back almost a decade. And like so many struggling with addiction, Mark doesn't fit any convenient profile. He's college educated, he graduated near the top of his class at UCLA Law, he was a successful entrepreneur and lawyer, and he has the most beautiful family, including 3 remarkable children. But over the course of the last 8 years, Mark's addiction to painkillers took hold of his entire life. And soon that life was in ruins. And by the time we learned about Mark's struggle, His family was destitute because of the money he had hidden and spent on OxyContin and other opioids, and then when those drugs became too expensive, he turned to heroin. His professional life was in shambles as he was unable to work or maintain a job, and his limitless shame was such that he tried to hide it all from his family until it was far too late. When Mark's wife finally shared the gravity of their problem, after years of keeping private their ravaged finances and her discoveries of drug paraphernalia and other telltale signs of Mark's addiction, she could no longer stay silent, if only for her daily fear that every phone call that she would receive would be from her children, finding Mark dead on the kitchen floor. My husband flew immediately to Los Angeles to help participate in an intervention and get Mark into treatment, and what followed instead was a harrowing, surreal 7 days as Mark's friends and family tried desperately to keep Mark from killing himself over one last hit, while also trying to navigate the frustrating and profoundly complex world of treatment centers and the insurance requirements needed for enrollment, a daily battle that presumed the person in need of help had insurance and also wanted the treatment, which Mark most certainly did not. So over the course of that week, I would get calls in the middle of the night from my husband telling me the fear that they felt as he and others once again looked for Mark after he had once fled his own home to buy more drugs, of the lies that Mark would tell, and even when caught red-handed, of the pain and the horror his family suffered throughout all of it. And I will never forget hearing what Mark, again a husband to a remarkable partner and a dad of 3 extraordinary children, told my husband about using OxyContin for the very first time. And I quote, "It was by far the single best feeling I had ever felt in my entire life. I would do anything to use it as much as I possibly could, and I would literally do it right now if you had it here." It was terrifying. I should note that they were ultimately successful to get Mark into rehab, even though he refused to acknowledge a problem, and only because they were lucky enough to have access to insurance available only to a small fraction of Americans who face a similar horror. It still, however, was not enough. Just a few weeks after leaving a well-known treatment facility, Mark relapsed and had lost everything but his own life, or really whatever his opioid addiction has left of it. So I am truly proud to be part of our discussion today and know just how important it is that we find a solution to what is by any measure a national emergency of the very highest order. It is vital, a vital conversation to have, not just with those who might know someone who's suffering the hell of addiction, but with the loved ones and children and anyone who might be at risk. But how to have that conversation and how to exactly know what the information that we need to have that conversation, that is what we're trying to do today. So to help start that conversation, please help me welcome John Ganter, the CEO of Robert Wood Johnson University Hospital.
Thank you, Liz, and thank you for that very powerful introduction. Good afternoon and welcome to Robert Wood Johnson University Hospital, a member of the Robert Wood Johnson Barnabas Health System. I'm John Gantner, President and CEO of Robert Wood Johnson University Hospital, and I am pleased to see so many of you here today to join in this important conversation about opioids. Substance use disorder is present in all of our communities and may have touched your life personally or professionally in some way. In fact, unfortunately, probably has touched your life in some way. As the academic medical center within Robert Wood Johnson Barnabas Health, our physicians and clinical teams are committed to making a long-term impact on those we care for with the disease of addiction. Today we are joined by a distinguished panel that represents experts from the New Jersey Department of Health, New Jersey Department of Human Services, the New Jersey Assembly is represented, the faith community, a family directly affected by substance abuse, Rutgers, New Jersey Medical School, Rutgers Recovery Housing, and our very own RWJBH Institute for Prevention and Recovery, which is a leader in New Jersey for substance use disorder with special focus on prevention and recovery support services. Thank you to all of the members of our distinguished panel. And a special thank you to you, Liz, and the entire WABC-TV team for partnering with Robert Wood Johnson University Hospital and with the New Jersey Department of Health and the New Jersey Department of Human Services to hold this very important town hall. Substance use is a discussion we need to continue to engage in, and bringing the right partners together, such as today's town hall, is another step, a big step, in creating prevention and recovery awareness and prepared communities. As you can see, we have a full and robust panel here today. We also have so many other experts who are making an impact in combating this insidious disease. Our system works very closely with Frank Gianassi, President and CEO of University Behavioral Health, which is part of Rutgers, and which provides resources statewide to address the needs of individuals struggling with this disease. Frank is a nationally recognized expert in behavioral health with strong roots in the field of addiction. So a thank you again today, everyone, for joining us, to our participants, to our panel, to the team from WABC-TV. I'm now going to turn the program back over to Liz, and we'll move forward with the program. Thank you very much. Welcome.
John, thank you. Now we have a special message. Now we have a special message from New Jersey Governor Phil Murphy.
Governor Phil Murphy here. Please accept my sincere thanks to each of you for joining this important opioid town hall. We know all too well that the opioid epidemic is a nationwide crisis, and we also know that New Jersey is not immune. In 2018, we lost more than 3,100 residents, too many friends, family members, and loved ones. By the end of June of this year, New Jersey had already counted roughly 1,400 opioid-related deaths, equal to the loss of 8 New Jerseyans every single day. North, Central, and South, urban and rural, young and old. This epidemic impacts all of us. Our administration is committed to combating the opioid crisis, not only to save the lives of New Jerseyans, but to lead the nation in finding lasting solutions to this epidemic. We're undertaking thoughtful, evidence-based strategies to increase access to prevention, treatment, and recovery services, as well as addressing the social needs of individuals, like housing and employment, and other issues that individuals face on their path to recovery. We have a laser focus on increasing access to medication-assisted treatment, and just recently undertook what is believed to be the largest single-day distribution in the country of naloxone, free to anyone, no questions asked, to prevent overdoses. However, we know we have a lot more work ahead of us. There will be successes, big and small. There will also be stumbling blocks, big and small. But together, we can remove barriers to opioid addiction treatment and increase knowledge of the risks of addiction and overdoses. We can remove the stigma that addiction continues to carry. Once again, I congratulate each of you for coming together to be a part of the solution. Your ideas are needed, and so is your commitment. Together, we can win this fight. Thank you all.
Thank you, Governor. And thank everyone for coming this afternoon. We hope to have a very vital, valuable, informative town hall. And to make it work, we invite your questions, talk to our panelists. I'll be introducing them in a moment. But before I do, I just want to mention that we are streaming this town hall online for viewers at home at abc7newyork.com and 6abc.com as well. And for those who are watching at home, if you'd like to join in the discussion, you can submit questions via Twitter using the hashtag #OpioidCrisis. For our audience members, and we do hope you have some great questions for us, Miguel, is Miguel running? There he is, he's in the back. You raise your hand and he will come to you with the mic. You'll be able to ask our extinguished panel a question this afternoon. We also have reporters Anthony Johnson from WABC and my colleague Trish Hartman from WPVI 6ABC. They'll be doing live hits for the evening news show during the town hall as well. All right, without further ado, let us introduce you to our panelists. And you can hold your applause until I introduce all of them. And we thank them in advance for being here, and we look forward to getting a little bit of wisdom from each one of them. So when I call your name, please stand very quickly. And we begin with New Jersey Acting Health Commissioner Judith Persicilli. Judith, thank you.
It's tight quarters.
Okay. Yeah, we're a little tight up here, but we know each other very well, and we'll know each other even more when it's over. Thank you for being with us. New Jersey Commissioner of Health Services, Carol Johnson. Assemblyman John Ormato, who represents New Jersey's 2nd District. Reverend Darrell Armstrong, pastor of Shiloh Baptist Church in Trenton. Angela Chicano, a supervisor with RWJ Barnabas Health's Peer Recovery Program. Angela, thank you for being with us. Dr. Christopher Freer, Regional Medical Director of Emergency Services at RWJ Barnabas Health and co-chair of the RWJ Barnabas Health Tackling Addiction Task Force. Also, Christina Fagan, Executive Director of the nonprofit organization A Change for Nick. Dr. Petros Lavonis, did he arrive? There he is at the end there. Okay. Thank you for being with us. He is chair of the Department of Psychiatry at Rutgers, New Jersey Medical School. Fred Munch, president of the Center on Addiction and former president and CEO of the Partnership for Drug-Free Kids. Keith Murphy, recovery counselor with Rutgers Recovery Housing. And last but not least, Dr. Aaron Zerbo, assistant professor of psychiatry at Rutgers, New Jersey Medical School. How about a big hand for our panelists this afternoon? Jen?
Thank you, Rick. In addition to the hat that I wear as Chief Medical Correspondent for ABC News, I'm also a board-certified OBGYN. So I'm particularly grateful to be involved in this discussion because, as many of us are aware, the opioid epidemic has hit the field of obstetrics and pregnant women and their families particularly hard. So for this town hall, we will really be focusing on 3 main areas: the topics of addiction, treatment, and then action and resources. So first, let's start by talking about addiction. It is not a choice, as many of us know. It is truly a disease, and it has touched so many lives and families here in New Jersey, and in fact the rest of the country. WPVI's Trish Hartman introduces us to a pharmacist and shows us how his son's death has helped reshape his own view of addiction and how he helps fight the crisis. Take a look.
At Power's Pharmacy in Browns Mills, Burlington County. But for owner John Power, his drive to help each and every customer is very personal.
It was Chris.
3 years ago, Power's 23-year-old son Christopher died of an overdose.
It was the nightmare of nightmares.
They discovered his substance abuse issues when he was 16, beginning a long family struggle to get Christopher help.
We would take him out and to different programs throughout New Jersey, Florida, and Pennsylvania, and he would always seem to gain 5 yards and then lose 10 yards.
Christopher died at a sober living home in Florida in 2016. As a pharmacist and a grieving parent, Power has a unique understanding of addiction.
And I've come to look at it now that it is a disease, and it is not a social stigma here or a moral failing of these people. They have literally changed in the biochemistry of their brain, and they are sick.
Power's Pharmacy was the first in New Jersey to receive a standing order to allow naloxone distribution without a prescription. The nasal spray can reverse an opioid overdose and save a life. In June, Powers was one of the participating pharmacies in New Jersey's first free naloxone day. Power explained how to use it to every single customer in memory of Christopher.
That single life-saving drug was not there for him the night he died. It begins to impact upon me how important it is to have that.
Hundreds of pharmacies in New Jersey now offer naloxone without a prescription. Power's goal is for addiction to be considered a chronic but treatable disease rather than a death sentence. Reporting in the New Jersey newsroom, Trish Hartman, Channel 6, Action News.
Thank you, Trish, for that incredibly compelling story. We will be talking about naloxone or Narcan in later segments, but first I wanted to go through some basics for everyone. Common opioids include heroin and fentanyl, but the most commonly misused opioids are actually prescriptions, such as hydrocodone and oxycodone. Nearly 1.9 million prescriptions for opioids. Think of that number, 1.9 million were written just in New Jersey alone between January and June of this year. More than 10 million people misuse opioids nationwide. 9.9 million of them misuse prescription opioids. More than 800,000 people misuse heroin. Nationwide, 130 people die every single day from an opioid overdose. So far this year, New Jersey has had more than 1,900. So we're going to start with the first question about addiction and really ask, who is at the greatest risk of addiction? I remember being in medical school and we learned about alcohol addiction, and the question was, what does the typical alcoholic look like? And then the professor said, you're all wrong. The typical alcoholic looks just like us. So I'd like to start with Dr. Freer. How do you know if a loved one has a problem?
Well, how do you know a loved one has a problem? Unfortunately, the adolescents are the ones that are very vulnerable to this disorder because of their frontal lobes aren't developed. So many times they make decisions that aren't always the smartest decisions, as we know with this. Signs you could see though of someone having a problem with withdrawal symptoms or nausea, sweats, jitters, and unusual behavior are some of the signs of someone in withdrawal.
And a typical person who struggles with addiction, does someone else want to take? Yeah, Dr. Lavonis.
I would say that the hallmark of addiction is a life out of control, but the way that we look at it is people who really try and they continue using despite knowledge of adverse consequences. I know it's terrible for me, but I just cannot help it. To me, this is the core problem of addiction. And then, of course, there are other things like an internal preoccupation. I constantly think about the drug. I cannot think about anything else but the drug. And the consequences in terms of one's health, in terms of one's relationships, in terms of one's legal problems that they may have, and so on.
So if you are a parent or a loved one and you are watching someone close to you who appears to be struggling and you suspect that they have a problem and they are in denial, how is it that you, I don't know if confront is even the right word, how do you approach that person once you suspect that they do actually have an addiction? Fred?
Thanks for bringing that up. Typically we have this conception that you have to do this big intervention and we have to get someone to treatment right away, but families can do a lot in terms of engaging that young person first in open, non-judgmental communication, asking and understanding why someone's using, starting the conversation without creating consequences right away, understanding where they are, and particularly reaching out for help, because it can be so stigmatizing to the family member to be struggling with a child's addiction or substance misuse that they're not going to reach out for help. So from a family member's perspective, it's opening the communications line, being non-judgmental, and then reaching out for help.
The stigma we are going to talk about. It is a
Great.
big topic that we're going to address.
Okay. Any questions from the audience? Oh, sorry. Any questions from the audience? Okay. All right. Again, if you have a question, raise your hand. We'll bring the mic right to you, but we'll just move on. Talking still about intervention. And is there a question? Miguel?
Yes. Hi. My question is, when there is an addiction, the addiction is usually the result of a condition, usually pain. My interest is in alternatives to treatments for pain that are non-addictive, that are non-invasive, that have no side effects. Are you looking at, or is the hospital looking at, alternatives for treatment to pain?
I think we will delve a little bit more in depth into treatment as this program continues. But does someone want to touch on that real quickly?
Yeah, so I'm happy to do that. I'm Carol Johnson from the Department of Human Services for the state of New Jersey. With the Department of Health, we have been working with hospitals across the state on alternatives to opioid prescribing. And I think we are excited about the fact that hospitals have been coming into our grant program willing to take on this challenge of reducing opioid prescribing where they can. We also are investing in community organizations who are doing the kind of community-based education that can help people understand that there are alternatives and to ask the questions before the prescription gets written so that there's an engagement with your healthcare provider about alternatives. So we have a lot of work to do, but we have a very interested and active healthcare provider base in New Jersey who's interested in working on alternatives.
And again, we will touch more on that a little bit later. My question has to do with the family members, the parents, loved ones who obviously are touched by this crisis as well. When should a parent, friend, loved one intervene? Is early intervention best rather than waiting until rock bottom? The best way to intervene, when should a parent or loved one intervene? Who would like to take that? Christina, Fred, Angela?
Is this on? Can you hear me? A parent should intervene right from the beginning, and you know it's showing that if the parent themselves have self-care to take care of themselves, it's the same old. If you put the oxygen mask on yourself before you put it on your child, you're more well equipped to handle the situation when it comes up. Because addiction is a family disease. Once someone in your family has become addicted to substances, the whole family is affected. So it's really, you need to intervene through the whole thing, through the whole process, and really educate yourself as to what the substance is, what the treatment is, what the signs, what the symptoms, the behaviors, and what treatment is available for that. Because you know, we want to be part of the solution, not part of the problem, you know, as a parent.
Just want to add one piece, which I completely agree. And very often the best intervention is prevention for any next stage. So wherever a child or loved one is if a family member is proactive, and that's the key, because often we just hope things will get better. We hope our kids won't use. We hope if they're using a little, it won't go to a lot. Is being proactive at that moment, engaging in the conversation. And once we do that, and once we say, this is a real risk, I should be worried, that all family members should say that regardless, whether their kid's 15 and going to a party or whether the kid's struggling, is to be proactive at every moment and engage in self-care. It's key. Thank you.
One thing that we all have a problem with, especially on the family side of it, is we fixed everything in their lives as they grew up. When they skinned their knee, we fixed it. When their bike broke, we fixed it. So it's natural to think that this is just something else I can fix. And obviously, we cannot do that. I think someone used the word stigma. That word is so powerful in this whole conversation that if you ask one thing that we need to do, that remove the stigma. It is a disease, and it should be treated like that.
I would like to pivot for a second before we can get too deep into the addiction part of it and go back to something that Fred mentioned about prevention. I'm going to put my surgeon hat on for a second because we are sitting at a major medical center. Every single day, patients have surgery. And I was trained to prescribe opioids after a hysterectomy, after a C-section. My mother just had shoulder surgery. She was given a prescription. I'd like to hear some of your thoughts on how we address this crisis without neglecting the people that are having, we're not talking about chronic pain management now, but acute short-term pain, because I'm sure there are a lot of people sitting here who would be afraid to accept that prescription, therefore afraid to treat their acute post-op pain. And it dovetails back into alternatives, safer alternatives, which I know could be a whole separate day, but I would like to hear some of your thoughts on that in terms of prevention of addiction.
So doctors are extremely competitive. So the quickest way you do this is you just put names up with prescription patterns, and you compare doctors to doctors and emergency departments to emergency departments. So I oversee 11 emergency departments, and by doing that, we cut the prescriptions in half, and 25,000 less opiate prescriptions went out. So that's the prevention piece. But if someone, you also have to change a culture of a doctor, not just to reach for a narcotic. It's a rescue medication, to talk to the patients about the dangers of the narcotics, talk to other alternative treatments that are available. We started working with our anesthesia colleagues to do nerve blocks instead of giving someone narcotics for hip fractures. There's other medications out there for disorders that we can use. So it's been a big culture change, because when I trained, if someone had pain and you didn't give them pain medicine, you were looked as you're not compassionate. So people reached for a narcotic much quicker than we should have. And it's gotten us in this situation we're in now. So it's really changing a culture of doctors' practice.
Erin, you want to?
Yeah, I would just also add that I think it's also the culture of our country, that the U.S. is 5% of the world's population, but we consume 80% of the world's opioids, and I don't think we have that much pain here. And so I think it's this conception in the U.S. that's kind of a pill for every ill. I'm going to go to my doctor, get a pill, and that's going to take my pain away entirely, or whatever problem I have is going to be completely gone. So it's kind of shifting out of that mindset and just realizing that you can get by with ibuprofen. I've talked to a lot of people who had like a hip replacement, and they were able to just use ibuprofen. I'm not saying that we want to take away opioids from people in severe pain, but I think we need to reset what our expectations are, that you can't get pain to zero. We need to do alternative strategies. We really need a cultural shift as well, in addition to doctors.
I was even reading something that it's okay for patients to have a little pain. I think as a culture, we're used to being, I shouldn't have pain. And we kind of have to get used to, it's okay to have a little bit of pain. I should learn to be able to live with that.
I mean, pain is a natural biological response to tell you should stop doing what you're doing. And so you don't want it entirely eliminated, but we just have this mindset, like, I want zero pain, and that's a big problem.
I just wanted to quickly tie together the last two questions, because you ask what families can do, and then we talk about the healthcare system. And often when you're seeing something in your child, you think, talk to your doctor. That's what you need to do. And so because, unfortunately, a lot of doctors didn't have as much training in this, Rutgers is changing that here in New Jersey, but you don't have that same go-to that you would with other conditions. And so that's why we're all collectively investing in sort of changing the clinical culture as well, so that families have a resource and it's not all on families to fight it on its own.
And also, I'd just like to add, to get our medical license recertified every single year in the state of New Jersey, which I have to do because I actually am not just a doctor on TV, we are now required to complete opioid education as part of our CMEs. So it is slowly happening, maybe a little too late or a lot too late, but doctors do have to get up to speed on that. It's not acceptable for a physician or a healthcare provider to write a prescription and keep refilling it with, indefinitely without evaluating that patient, screening them for dependence or addiction, and offering safe alternatives. Did you want to comment?
Yeah, I was going to add that the notion of counseling, therapy, and psychological approaches to dealing with pain, right? So mindfulness, meditation, there are opportunities for kind of clinical approaches that uses psychiatry, psychology, and how to manage pain and how to get to the root of whatever the symptom is, as opposed to just putting a Band-Aid and treating it.
Dr. Livonis, can you comment on what about the difficult intersection when you're dealing with someone who, as I like to say in medicine, you can have more than one problem at a time in life. So someone who's suffering from mental illness and dependence or addiction at the same time.
The short answer is that you need to address both. You need to address the addiction and you need to address the mental health issues. And one of the worst things that we have been doing is to say, I'm only going to look at your addiction after the psychiatrist has taken care of the mental health, and vice versa. I'm only going to start looking at your depression or your anxiety or your PTSD after you stop using the drugs. And we miss the ball that way. We need to address both at the same time.
I think it's important to note that the Department of Health has looked seriously at the integration of mental illness, substance use, and primary care. And we now issue single licenses. Heretofore, you had to apply for 3 licenses to open up a center that would pay attention to the integration of those three areas. So that's a big step in the right direction in encouraging providers to look at mental illness, substance use, and primary care together.
An all-in-one type deal. I want to return back to the topic of stigma and addiction, and specifically opioid addiction, and I know that you are all experts in this. So I would like to hear from several of you. And there are so many different levels when you're talking about stigma. How do we begin to change the idea, the public perception of stigma, that addiction is simply a morality or a weakness thing versus a medical illness? Who would like to start off with that?
I just want to start by saying the first step in this journey for all of us, providers, the community, is to have more understanding of our own implicit bias, that unconscious bias about something we all have deep inside of us. And I don't care if you're a provider or any one of us, as it applies to substance use disorder. If we don't address our own biases, which are in providers every day, we will never go on the journey of removing the stigma.
And for those who are suffering, it is a paralyzing factor in allowing them to ask for help.
If I can just raise the issue of a study that was done in 1985, ACEs, Adverse Childhood Experiences. When Dr. Bob and Dr. Felitti did the original study on obesity in San Diego, in the population that was majority white, insured, and suburban, little did they know they would stumble across, right, the issue of how early adversity in childhood would come back to affect us in our adulthood. And so much of the stigma that we see is involuntary, because I always like to say, from a faith tradition, if you don't deal with your stuff's going to deal with you. The reason they were overeating in an obesity study was because so many of those people had been abused as children, sexually molested, and or violated, and they had repressed their trauma. So trauma, toxic stress, trauma, literally is at the root of so many public health issues that we must deal with in America. And it becomes an issue not just of stigma. Trauma crosses all races, all religions, all regions. And yet when I concentrate poverty in a certain area, I increase trauma. And when I increase trauma, I increase the co-occurrence of not only substance abuse, but domestic violence, child abuse. All these issues are co-located, co-occurring, and really it deals with, in most cases, childhood trauma. All of us have experienced some adversity in our childhood. The question is, have we repressed it, or are we getting a treatment for it?
So how has the faith-based community helped try to change the mentality of the stigma as it pertains to opioid addiction?
Well, number one, I always want to say that, particularly in African-American communities, there's a notion that counseling and therapy is somehow a taboo or wrong. That if I admit that I have need, that somehow I'm admitting that I'm weak. And really, I try to reverse that from the pulpit and through public health messages, that the person, intelligence is not always knowing the answer. Intelligence is knowing where to find the answer. And if I can refer someone to treatment and counseling as a faith leader, then I think I'm doing a great service to that person. Just praying about it isn't going to be the only answer. Prayer plus some treatment is a good combination.
So, I'm sorry, go ahead. What were you going to add?
So I think for years all we saw in the news and in newspapers was the negative effects of substance use disorder. It wasn't until people started to speak out and say this is what it looks like to recover, because people with substance use disorder recover every single day in our communities. In our hospital system, I watched the transition of our hospital system accepting and finding out that it was frustration. It was frustration that they didn't know the answers to solve this problem. Our doctors, our nurses, our physicians, they really didn't have an answer for it. And working together with the peer recovery program and recovery specialists was really able to help them understand what substance use disorder looks like and see the other side of it. I think so many times we only see the negative effects of it instead of seeing all the positive things that people in recovery do.
I was going to ask about, we talked about trauma. What if the victim is a teenager, not an adult yet, someone who might not be in touch with the traumatic aspect of their life? All they know is that they need a release or they need some type of relief. How does a parent, and I ask because I have a 17-year-old son, but how does a parent deal with a young person in their house who they know is going through some type of situation, might have turned to or thinking about turning to opioids? What is the way a parent or a loved one should handle someone who is not an adult yet, but certainly the trauma is setting in?
Well, first, to kind of echo what the pastor was saying, I'll go with something here. Rules without relationship lead to rebellion. So part of it has to do with developing a relationship first with your child. That's the first thing. The other part of it is being in a place to actually talk to them about their issues or their concerns and understanding where they're at and where they're coming from. Oftentimes, as adults, we're talking down to young people, expecting them to understand the world as we understand it. But their process of how they look at things because of brain development, identity development, is totally different. And oftentimes it's very difficult to get, especially, your son, for a lot of reasons, toxic masculinity being one of those reasons, into treatment, into therapy to look at maybe some of those things that are going on. But initially, you have to be able to learn how to have that conversation. And you don't have to necessarily be that one. If you know someone that's got access to your son emotionally, they may be the person that you can go to, and you don't have to be in it alone. And that's part of the stigma and stuff that we're dealing with. I mean, and to go back to the other part of the stigma, for a long time, we talk about the current opioid crisis. It's really been an addiction crisis. It has been a war on black and brown people. That is just facts and how it's been. So part of that stigma has led to discrimination because certain people have not had access to adequate and consistent and reliable health care. So that's also part of that built-in thing. How am I supposed to be as a man? How am I supposed to be as a black man in society? Can I actually talk about what's really happening to me? Who are safe people for me? And now what's going on, because it's affecting different populations, we are now beginning to have that conversation and reducing stigma.
Can I also just add the notion of, there are a lot of programs that are focusing on positive parenting. And so the notion that kids don't come with instructions is right. We have to figure out how to actually give constructive, instructive parenting knowledge to newborn families, or families with newborns. And so there's a host of funding. Billions of dollars have been poured into home visiting programs, nurse-family partnership, parents as teachers, Healthy Families in America. I sit as a board member of Prevent Child Abuse America, and in order to prevent child abuse, you have to make families stronger. How do you make families stronger? Give them the resources that they need at the ground level before they get into crisis. We often wait to pull the children out of the river downstream. Somebody's got to go upstream and figure out why are their children falling in the river in the first place.
We do have a question from our audience member, which I'm going to get to in one quick second. But Keith, you mentioned a very important word, and that's alone. And I think so many people, the person who is suffering is alone. The families feel alone and isolated. The isolation can be paralyzing. But really, addiction, and I think people who are going through this are learning that addiction is a family crisis as well. And Christine, I'm wondering if you could talk a little bit about that, because it's not just treating the patient, it's also treating the family.
So as I said before, self-care is really important, because when the shoe drops, it's really, you're brought into this storm, and being able to have support and it is really important. One of the things I wanted to mention was prevention. We said that prevention is the answer. I'm a preventionist, so prevention from an early age and taught through adulthood is the answer. Teaching kids good coping skills. Telling them that feelings are okay. It's just what you do with your feelings, right? Learning to express yourself in a positive way, and positively reinforcing our children, not negatively reinforcing our children.
And acknowledging your child's feelings. I can
Yes,
see that you're
acknowledge their
upset.
feelings,
Let's talk
right.
about
letting
why
them
you're
feel
upset.
them, letting them talk about that, letting them know it's okay to feel a certain way, and really reinforcing them with positive, positive reinforcements, love, compassion. Yeah.
We do have a question, Miguel.
I'm Larry Redmond. I'm the chairman of Middlesex County Local Advisory Council on Alcohol and Drug Abuse. I'm on the board of the Middlesex County Recovery Community Center, and I'm a person in long-term recovery. I've been clean and sober for almost 33 years. That wasn't why I threw it out there, but thank you. My question is this, well, not just, but I went to my 50-year high school reunion. Went to a private school, 130 kids in my graduating class, and doctors, lawyers, all the good things when I went to the reunion. And I can assure you that I was one of a very small group who turned out to be heroin addicts. And it predates the opioid crisis of today. There were no oxycodone or any of this kind of stuff in 1967. At least the doctors weren't giving it out, not to me anyway. But, so why, and I always ask myself this question, so why me? What drew me into it? I drank in high school like most people did, and, but there was something about that feeling. I always say I was never a social drinker. I was always in it for the high. What made me different than those other people that I had to suffer for all those years before I found recovery? I'm kind of hoping that doctors would be able to answer that.
Dr. Lebonis?
Yeah.
We're competing.
Yeah, we're competing. Go ahead, Erin. Go ahead.
So I think what you described is the best question that you can ask someone. What happened the very first time they took that substance? Because if they have that feeling that I felt normal for the first time, or I had this amazing feeling, it alleviated something for me, that's a sign of self-medication, that it kind of fixed something in that person, and that's a risk factor for going down that road and becoming addicted. And I think just overall, we need to be much more open-minded about this. What's happened with this opioid crisis was basically a national experiment where we said, let's give everyone prescription opioids. And this very tiny research, which wasn't even research, it was this very small study that showed people leaving the hospital that they had a very low risk of addiction. That was just based on chart reviews. It wasn't true data. And this got promulgated to all these doctors to say you can give opioids to people, and if they don't have a family history of addiction, they won't get addicted. And we found that that was terribly wrong. So right now, we don't have a good predictive tool. And there's the opioid risk tool, and there's a few tools, but we don't have a great way to predict who's going to become addicted. And so that's why exposure is really the key. We want to try to decrease exposure as much as possible. And when people are exposed, if they're feeling this immense relief, if they feel it was amazing, for other people to try to notice that quickly and get them the help that they need, or get them in a different direction. Because right now, it's really trial and error. I don't know what you want to add to that.
That's perfect. I just want to add that the vast majority of people who got addicted to opioids in Kentucky and Ohio and Tennessee, they just did not have the family history of addiction. They were not self-medicating against any kind of psychological problem. Their peers were not using. They just simply had a lower back pain. They went to the doctor. They were given these massive amounts of oxycodone and other opioids, and before you know it, they were addicted. And by the way, again, the vast majority of these patients did not take a single pill above and beyond what the doctor prescribed for them. They were not doctor shopping. They were not really going above the recommended doses. They simply followed directions, and they end up getting horribly addicted.
Are there any other questions regarding addiction? Oh, go ahead, Miguel.
Good evening, everyone. I want to thank the panel for coming out and finally hearing our cries. My name is Lisa Talbert. I'm in recovery as well. I work for Woodbridge Addiction Services, and I used over 30 years of my life. And something I want to piggyback off what Mr. Murphy said. I used for a very long time, but it's only finally getting addressed when, what's your guy named Mike? Whenever he used, it gets addressed in. It only gets addressed in, but when Raheem and Jaheim and everybody else use, it doesn't get addressed. Now it's nationwide because it hits home, it hits suburbia, it hits the millionaires, it hits everybody in that format. But this been going on forever. But what I really want to say is with the pharmaceutical company is you get these people off of drugs and then you put them on Suboxone for years, or you put them on methadone for years, and the pharmaceutical companies is still making money. So how do you get them off of Suboxone and methadone?
Well, that is a very good transition, a very good question into our next segment, which is about treatment and talking about medically assisted treatment. And we are going to get to that in 1 second. So we are going to go into treatment. And for families, you know, they may have won the battle about acknowledging the addiction, but the war has just begun. And chances are you may not have any idea of what treatment entails and what kinds of treatments are out there. It is really a lot of trial and error for many families and research to figure out what type of treatment is best for your loved one and how to get it and how to pay for it. Naloxone also playing a vital role in expanding its availability, also key to helping turn the tide of this epidemic. For someone who's overdosing, as we all know, naloxone blocks or reverses the effects of opioids. It's the first line of defense in an overdose. New Jersey has more than 8,000 naloxone incidents so far this year, and recognizing the importance of this one particular drug in this epidemic, the state did have a one-day pilot program giving away free naloxone over the summer, and it was very effective. For many with opioid use disorder, naloxone may be the first step towards treatment. As for long-term recovery and treatment, there are lots of options out there. And WABC reporter Anthony Johnson introduces us to one woman's journey to treatment here at RWJ Barnabas Health.
Being around addiction started early. She was an only child living with a parent who was addicted to alcohol. So when her mom died, Amanda went into a tailspin.
The day my mom died, I lost who I was. I ended up I lost my house. I put my children in foster care.
At one point, Amanda found herself living on the streets of New Brunswick, sleeping on the steps of the library and panhandling just to buy heroin.
It takes control over everything. Your entire body, your entire mind.
She even thought about doing the unthinkable.
I just got done shooting my heroin. I turned around and put the needle back in my arm with air in the syringe, and I was going to take my life.
But in the midst of her misery, she met Al, a recovering user who now worked for the RWJ Barnabas Health Institute for Prevention and Recovery as a treatment specialist, and he knew the pain of addiction.
I watched it happen, and I couldn't stop it. There was nothing I can do to stop it.
But with the threat of jail or worse, Al turned his life around and joined a community of supporters. And one day, after some persistence, Amanda asked for help.
She made that call, and that was huge. You know, that's, to me, that's the hardest part for me, was asking for help.
Now Amanda has been clean for 9 months. She is reconnected to her children and other members of her family as she recovers. She says the services provided by the RWJ Barnabas Health Institute for Prevention and Recovery and Al, her peer counselor, have given her new hope.
I remind myself that I'm worth life.
In Eatontown, New Jersey, Anthony Johnson, Channel 7 Eyewitness News.
Anthony, thank you for that piece. So peer recovery, one element of treatment. Medically assisted treatment, which is what you were talking about, also known as MAT, is proving to be one of the most effective ways of treating someone with this disorder, and WPVI's Tris Hartman has much more on that.
John Brooks Recovery Center in Pleasantville, New Jersey.
That's like one of those Jersey.
In addition to their work here, professionals at the center deliver medication-assisted treatment, known as MAT, to the incarcerated at the Atlantic County Jail.
Well, I became a inmate December 28th, and they had helped me through withdrawal.
Linda Shulo says her addiction started 15 years ago when she took pain medication after gastric bypass surgery. Her turning point was when she was incarcerated and received methadone in jail through a first-of-its-kind program funded by the state.
The withdrawal process and the hopelessness, leads to suicide attempts, and it's a real problem as an administrator of a jail, and this has really helped curb that.
Officials say many are able to continue recovery treatment at centers like John Brooks.
Probably the most important part is the discharge planning, is to link them to services once they leave the jail. Otherwise, what's the point?
Folks at John Brooks say the program allows them to reach clients at a critical time.
A good 70% of the people that enter the jail have an opioid problem. And most of them are getting the money for the opioids through illegal activity.
Those who work in recovery say medication-assisted treatment is the key to sobriety for many people. State officials say they are working to remove barriers.
We were previously requiring people to ask their health insurance company for permission before they could use MAT. Now we're saying once your clinician tells you MAT's the answer for you, you can start using it right away.
Medication-assisted treatment is now expanding into other county correctional facilities in New Jersey. Officials say putting more people on the path to recovery. Reporting in the New Jersey newsroom, Trish Hartman, Channel 6, Action News.
Trish, thank you for that. Before we get into the details of MAT, I just want to take one step back because as we have talked about, addiction is a medical illness. Why is it that there are so many different types of treatments that are out there? From 12-step programs, abstinence programs, MAT treatment programs, and when we are looking at other medical illnesses like cancer, there is a diagnosis, there is a treatment, it is very black and white and very straightforward. Why is it in this medical arena it is gray? Dr. Livonis?
It is not gray. It is black and white. If you suffer from opioid use disorder in 2019, you do need to get on medication. And most likely that medication should be buprenorphine. Maybe methadone, but most likely buprenorphine. And it is very clear, and the evidence is all there. I want to address your question. None of us likes to take medication. I would much rather not take medication. None of us wants to take any medication. But if it so happens that you suffer from diabetes, insulin-dependent diabetes, you better have your insulin. And of course, your insulin is manufactured by some pharmaceutical company, and yes, there are all kinds of profits out of that, but your body needs it. If you suffer from schizophrenia, from hypertension, from any number of other disorders, you may need medication, and you may very well need medication for a long time. Not just for a few days, not just for a few weeks, but for several months, perhaps several years. And that's what happens with this illness of opioid use disorder. A lot of people, the majority of people, will need medication.
So getting back to treatment, and again, my question, I always ask my question from a parental standpoint because my whole world exists around a teenage son who I'm just trying to get into college and, and keep him as healthy as possible. But what should parents expect about the process of getting into treatment? Because so many of them, including me, don't know how much of a roller coaster it could be, the ups and downs, the travails. What are the expectations a parent should embrace, should know about when their child, God forbid, has to embrace a treatment program?
I'm going to start. One is what you said, what Liz said, this is a journey. And setting up the expectations that there's no one and done, there's no magic pill, whether they're taking medications for addiction treatment, whether they're not, is the expectation is that it's a journey. No treatment center is, whatever they're promising when you're sitting on the hills wherever or in Newark, it doesn't matter, that it's a journey. Navigating that treatment system, understanding what those treatment options are, and empowering yourself to be an informed consumer is one of the most important things family members can do because you are the advocate for the individual. You are the person who's going to go into the treatment center and understand whether they have the right types of treatment. So being an informed consumer, navigating all the different types of treatment, but most importantly, when that young person, old person, whatever it is, gets out of care, is knowing that that's when the real work happens. It doesn't happen when they're in there. They're in a controlled environment in some way, even if it's outpatient. Real work happens, peer recovery, connecting people, keeping them engaged, being a part, not saying, I'm in recovery from heroin addiction and I got out of care. And about 3 months in, when I was in recovery, my dad said to me, like, oh, do you want a glass of wine now? Are you good? And it was all out of love. It wasn't a bad, it wasn't, And so empowering yourself, being informed, and being a part, because this is what families, the family, the loved one, the friend, can do so much to empower recovery.
So I would just like to add, that is a lot for a family member who is in crisis to have the knowledge of navigating through treatment and what level of care. I think as a community, we need to recognize that the disease of addiction is the only disease that isn't addressed at our hospital systems. So the peer recovery program at RWJ Barnabas recognized that, and we are able to have families and citizens come into our hospital system when they're in that crisis. So your daughter, your son just came to you and admitted to their substance use problem. Now what? You Google online treatment facility and a bunch of unethical places could come up. You're not really sure what you're dealing with. We should have a safe zone like a hospital. All over the country, we're told that when we are in crisis, we go to a hospital, we call 911. Why is it with substance use disorder that we don't do the same? So I would like to just add with the peer recovery program is that you have professionals to then take over and say, assess the individual on top of the peer-to-peer. I recently just became a new mom. So people told me what it was gonna be like as I was awaiting the arrival of my son and how I was gonna feel. But nothing in this world could prepare me for motherhood. Today, I'm navigating the system of being a mom, and who do I call? I call mothers who know what the answers are to my question. That is the same for peer-to-peer. You're having an individual, when a peer recovery specialist comes in to do, to sit next to a person who's still suffering, they're able to say back to the person when they say, you have no idea what I'm feeling, they're able to turn around and say, no, I know exactly how you're feeling because I've been there before. And that makes all the difference.
You asked a question about cancer. You asked a question about all these other diseases. The medical world has no way to see what brain disease is. You can see cancer. You can see kidney problems. But you cannot see brain disease, which is unfortunately a mental part of it and the addiction part of it. And someone asked about why this person and not that person. The way I look at it is you were pre-wired. You were pre-wired to have this disease. So you can look back into your family, you might find it. But if you had never broke that bone, if you have never been associated with an opiate, your life was going to be great. But if you didn't, this is the road you're going to go down. So, and I want to go back on a little bit of the parenting. Parenting today is way different than parenting when I grew up. It is because of the digital world. Parents shouldn't be their children's friend. They should be their parent. And that's what we have to do. I sort of laugh sometimes, well, you know, I respect my son's privacy. I would never go into his room. If I tried that, it wouldn't have ended well. As a parent, you should know exactly what's in that room. You should have every password they have. You should be able to go in, look on their laptop, look on their phones, because once again, you are the parent. So there's a whole bunch of things that we can try to do differently, but one of the things is we can try parenting.
Yes.
So I just have 3 quick things for parents who are concerned that their children may have an opioid use disorder. 1, make sure you have naloxone. Keep it handy, keep it ready. You can save a life, you can reverse an overdose. 2, know our 800 number here in New Jersey for our 24-hour, 7-day-a-week addiction hotline, 844-REACH-NJ, 24 hours a day, 7 days a week. 3, to Dr. Lagona's point, medication-assisted treatment works. Treatment works, recovery is possible.
Thank you for that. Chris, did you have a...
Yeah, I just want to make a comment on treatment. So we see almost 1 million patients throughout the emergency departments at RWJ Barnabas Health. And in 2015, if I have a heart attack, I call the cardiologist. If I have a trauma patient, I got a trauma team. Stroke, so on. If someone got Narcan and almost died, they got a couple photocopied papers and they got discharged. That's awful. So fast forward, Angela and I work together. She's become part of the care team with the doctors and the nurses and the PAs. She, being a former patient, has showed us the way of how this is a disease like diabetes and changed the stigma. So if you don't believe first in treatment that it's actually an illness as a doctor, you're gonna get nowhere. The other thing is we have 100 recovery specialists across our hospital. So we're the safety net. Now, like I call a trauma surgeon, I'll call Angela in because she has a much better chance of breaking down barriers in a peer-to-peer program and navigating the patient that I don't know how to navigate through because I have all these other patients to take care of. It has been a game changer, and it's changed how we treat these patients with the recovery specialists across the system.
Thanks for sharing that, Chris.
Can I just add something? I just wanted to add about the family component because we do have family peers in New Jersey also. We have peer recovery specialists in all 21 counties of New Jersey, and we also have family peers that cover the northern, central, and southern. What did I say? Did I say southern? So we have 3 family peers. And the Partnership for Drug-Free Kids has family coaches that people can reach out to. There's resources there. There are resources.
Before I get to the next question, I would like to ask you, the audience, if we could see with a show of hands, how many of you either personally or know someone close to you has struggled with opioid dependence or addiction? So I think we need to look around and realize this is no longer a situation where we can say it's not going to happen to me. I think we can see that it actually can. Staying on the topic of treatment and dovetailing on what has already been said about the value of medication, I think we do have a problem in our society, in our culture, because we tend to look at things in extremes, right? We tend to look at things like either I'm going to ask my doctor or my healthcare provider for a prescription and pop a pill and it will cure everything, or I will do it naturally. And you spoke to this, Dr. Lavonas, before. If you have high blood pressure, you would treat it. If you have diabetes, you would treat it. We need to look at addiction in the same way. So I want to ask you, Dr. Zerbo, if you can speak in a little bit more detail for people who may not be familiar with MAT, medication-assisted treatment, and what's involved and why it's so important and so effective.
Absolutely. And I think this is the most important thing because opioid use disorder is different from other substance use disorders just because of what's happening in the brain. So all of us have a natural opioid receptor system, our endogenous opioids, and we use that naturally to relieve emotional and physical pain. So the other thing to point out is that opioids are excellent emotional painkillers just as much as physical painkillers. So the problem is that when someone takes external opioids in large amounts over a long period of time, it downregulates your internal system. So you basically have too low of an opioid system. So if you detox someone from that over a period of 3 to 5 days, and I think anybody who has experience with the treatment system knows this, you're not going to feel well, and people relapse immediately. We see a 95% relapse rate after a short detox like that. So what that's telling you is that your brain doesn't have time to regenerate that opioid system and get back into balance. And that process actually takes weeks, months, and up to over a year for most people. And so it's this idea of, having this terrible heroin addiction for years. People get in the hospital, they're kind of seeing the light, they have a lot of motivation, they really want to be well and get sober, but they rush it, and then 5, 7, 10 days later, they're feeling jittery, on edge, not quite right, and those are all symptoms that their opioid system is not back online, and they're very likely to relapse. The danger there is after a period of abstinence, if you haven't had opioids, that's when you see an overdose death. And so over and over, we see the story of someone going into treatment, doing really well for a week, a month, 6 months, and then they relapse one time and they end up dying. And we just see that so often over and over. So the whole idea with medication-assisted treatment, and more specifically methadone and buprenorphine is the same as Suboxone, those are long-acting, slow-onset opioids that replace that deficit in your brain and allow you to live a normal life and get everything together. Reestablish friendships, figure out what kind of work you want to do, really establish meaning and purpose in your life. And the idea would be to very slowly taper off that after you've been on it for a year, 2 years, 10 years, 20 years. There's no rush to get off of it because we don't know. Some people might have an endogenous opioid deficit. They might be born with that wiring where an opioid opioid makes them feel better, and why are we trying to take it away from them when we know that that could result in their death? So I completely understand the sentiments about pharmaceutical companies. I share them myself. I think pharmaceutical companies have way too much influence over doctors' education. I know that from going through medical school. It's definitely true. But we've had methadone since the 1960s, and the data on this could not be more clear. If you're out of medication-assisted treatment, you're 66% more likely to die, and we see that study after study after study. So in terms of medicine, this is gold standard, high-quality evidence, and if it wasn't so emotional, and if people who were addicted didn't look so normal, kind of walking, talking, and looking like they're making voluntary decisions, this would not be any kind of an issue. Just every doctor would learn in medical school, you put people on MAT because it saves lives. So I think it's just addiction is such an emotional kind of very heartfelt issue, and it makes it hard to understand this. But we've just seen so many people do very poorly without medications. And I'm not saying that you can't recover without meds, but you have to give people that option because they're so much more likely to die, and they can have a much more comfortable recovery with it, at the same time allowing their brain to heal. And I know we don't have much time to get into this, but when you're addicted, your prefrontal cortex is downregulated, and your primitive brain is very strong and driving all that action. And that's why when you see someone in the middle of an addiction, they don't look like someone you know anymore. They're kind of crazed and just, you know, after that drug, and that's all they care about. I think Liz described that with her friend's husband. And that's literally just a brain dysfunction. The amazing thing about methadone and buprenorphine is, though, even though they're opioids and they can be abused themselves, because they're so long acting and slow onset, they allow a steady state level, and the brain actually recovers. It's these spikes of intoxication and withdrawal that keep the brain in this imbalance. And so while people are on methadone and buprenorphine for that year, 2 years, 3 years, their brain is in recovery and getting better all the time. And we know this from neurochemical studies, from brain imaging, from all kinds of science. So it is recovery to be on medications, and it saves a life.
Yeah. Why is it then that there is a stigma of people saying, well, you're just trading one addiction for another? And how do you fight that?
I think some of the problems, and what we see with family members in particular, is that it is an opioid. And so there's a differential effect. It's like, oh, they're still getting high, rather than understanding that it is a harm reduction way. It could be a treatment for low levels of opioid receptors, whatever it might be, is that there's a stigma. It's like it's still getting high. And so I think educating and helping people understand that, one, it saves lives. There's just no doubt about it, and that's our goal, is to save lives. The other is that people can get reacquainted and understand, reacquainted with their lives, reacquainted with their friends, reacquainted. But then the other piece is, I think there sometimes can be a push to give someone medication and that be it. And what we see very often is there's not counseling associated with it. So I think as a community, we have to be very clear to include behavioral counseling and lots of supports for individuals on MAT. And if we don't do that, we know that many people on MAT are using other substances while they're doing it, and they're getting high in other ways because they don't have those external supports. So integrating counseling and support with MAT is crucial for us to get to the next level to allow MAT to work.
So I will add, sometimes stigma is baked into the policy environment. So when we came in the Murphy administration and we took a look at how I run the state's Medicaid program, about how we were treating opioid use disorder, it was clear we were making it hard to get medication-assisted treatment. We made people go through prior authorization. We didn't necessarily pay as well for the services as we could. We weren't paying for the navigation services to get people to counseling and the support services. We didn't have supports and training for healthcare providers to be able to do this. So we have changed all of that. We have now said there's no prior authorization. When a clinician says you need medication-assisted treatment, you get medication-assisted treatment. We've created support networks for healthcare providers to learn how, and have other addiction experts like Dr. Zerbo be a resource for them so that they can do medication-assisted treatment. We've changed the way we paid for it so that more providers will do it. We needed to change the way the policy environment was structured so that we could meet people where they are and actually encourage the use of medication-assisted treatment.
To be able to prescribe buprenorphine and the other drugs that can help with medically assisted, like why can't every primary health care physician help do that?
So I'm waived, and I got trained by Dr. Lavonis and Dr. Zerbo. You know, I can prescribe 30 Percocet, but I need to take an 8-hour CME to get waived to treat Suboxone.
Right.
It's a federal, I don't get it. Like, so I think that creates a little bit of a stigma for doctors that the DAs, I'm gonna get in trouble and they're gonna track me if I do this. So a lot of this is education that, you know, this is a great drug, this is gold standard and standard of care, and doctors are hard to change their practice, but I think that is one of the reasons.
There's a situation with the courses that we teach to waiver people. Erin and I have been teaching all these courses, and we love the course. I think I've done more than 100 of them already. But on the other hand, I would much rather not have the course. I would much rather not require physicians to take this extra step, extra barrier in order to prescribe buprenorphine. As very well said, would allow physicians to prescribe far, far more dangerous medications without any extra training, and then yet for this particular one we have added a barrier that needs to get away.
May I jump in for one quick thing too on this? But listen to the language that they're using. We're calling it MAT. We're calling it something different than recovery and help. So that also adds to the stigma. That's the built-in language. Why is it different than anyone else who's being treated with anxiety to take a benzo? No one says who's dealing with anxiety, oh, you're on MAT. So we have to be careful in the language that they use because it's stigmatizing. It puts people in a different category, and they're further oppressed and further pushed to the margins, whereas they can't come up and be upfront about what's actually going on in their lives. And that's also a double thing that goes on in traditional abstinence-based recovery communities, where people who are on MAT aren't allowed to freely go in and be their whole selves. There's something that they have to hold back, which increases shame, and they're more likely not to say that I need additional help and support. So we continue to discriminate and oppress people who are deeply, deeply marginalized because we don't have a language or a way to deal with people who are actively using drugs. That's just bottom line.
Dr. Zerbo, did you want to add something real quick? Because we do have an audience question that we're going to take in just a minute. Was there something you wanted to?
I just wanted to mention, I think we've kind of talked around it a little bit, but the war on drugs is also a huge factor in this. And we've had prohibition in this country for over 100 years. So the 1914 Harrison Narcotics Tax Act is what functionally started prohibition for heroin and cocaine. If you look back before that time, it's really fascinating. There actually wasn't necessarily a major problem with addiction. People were using morphine and cocaine. You could order it from Sears and Roebuck catalog, and they would send you a pocket cocaine case with an injectable syringe. So these were medications that were used in the community, and after the Tax Act passed, you pushed it into the black market, and now you get adulterated product, which is at 1,000% of what it was in the legal market. And we're seeing the ramifications of that right now with fentanyl being found in heroin, and this huge overdose epidemic is not turning because of all this fentanyl. And so I think we need to take a larger step back and said we've had over a century of prohibition. We're saying this is a medical disease and a healthcare issue. Why are we prosecuting people? Why are we putting people in jail and prison? And they're all black and brown. And so this is really a racist structure that's been set up, and it's baked into the cake of our society at this point. And so now doctors are stigmatized as well toward these patients and not treating them. So we have a much larger issue to deal with, and I think we really have to tackle the war on drugs if we're actually going to solve this.
Thank you. All right. Thank you. Miguel, you had someone to a question? Hi.
Hi, good evening. My name is Melissa, and I work for a nonprofit organization as a drug and alcohol counselor for over 10 years. I'm also a peer recovery specialist for RWJ Barnabas, as well as a person in recovery from the disease of addiction. And I want to go back for a minute. We talked about prevention. We talked about young people a little while ago. And in one of the positions that I had previously, I worked with youth. And what I found is that a lot of times these children are going into the medicine cabinets at home, because we talked about the prescriptions that were being prescribed for people who were in pain. And because of the fact that it's so readily available, you could go into anybody's prescription, whether it be your own house, somebody else's house, in the bathroom, go in the prescription in the medicine cabinet and find a prescription, take it. And a lot of times it's about access. Now we do a prescription drug take-back program once a year or so. Can someone talk to why we don't make it more do more education with people about what to do with the medications once they're finished with them? If you don't completely take all the medication you have, what you should do with them, safe way to dispose of them. That's not a conversation that I hear people talking a lot about. And anybody, I guarantee you 80% of the people in this audience have medication near the cabinet at home that could be easily abused by anybody who gets into their bathroom. And this is how people are getting hold of medication, especially young people, and they have no idea what they're taking. And a lot of times that is the gateway to people getting into substances and using substances more readily because they're available to them.
Briefly, thank you so much for this question. 2/3 of kids and young people and young adults who misuse medications, and adults get them from medicine cabinet or a friend or acquaintance. We also know that when individuals get a medication, that the healthcare system doesn't set up any oversight what they do with that medication after, and they're getting even 7 days of pills for something that takes 2 days. So there's a couple things. One is take back for sure, but people aren't aware of it. So we need something in health systems where you get a prescription and it's very clear about what to do that. There are different solutions that people can use that can get rid of that medication, the active effects of that medication. I always say to people, I know they don't recommend it, is put it in some coffee grounds, wet it, and throw it out. Get rid of that, and we should be saying that. We're working with the FDA right now on medication alternatives and a safe prescription program that someone can just text RX to a short code, and once they get that prescription, they'll until the prescription's done, of 3 to 5 days for any controlled substance. When that prescription's done, and they'll tell them exactly what to do. They just say done. So there's a number of things that people are doing, but we are not doing enough because 2/3 of kids are getting those opioids from their medicine cabinets. So thank you for that.
Yeah.
There is legislation out there now that mandates the pharmacy who gives you the prescription for an opiate also has to explain to you how to get rid of excess pills. They also are able to give you what it takes to do that. There's certain bags called the Tira bags where you can put pills in it, shake it up. It now goes into the garbage. So we are trying to address that, and I do believe that the pharmacies should take that role of saying either bring it back here or this is the way to get rid of it.
There is a practice with law enforcement where we do gun buybacks, and so houses of worship have often been locations where we invite community members with no stigma, no retribution to bring legal firearms back. There's some conversation among clergy friends of mine about prescription drug drop-off locations. That as a house of worship, tell your congregation, what do you do with your emptying your medical cabinet? Bring it all to church. Bring it all to your temple, bring it all to your synagogue. And then we work with government, local, state, municipal, county, to then figure out how to dispense of it. And so I'd like to be able to report to you at some point later that we're going to do perhaps Trenton's first drug drop-off at Shiloh Baptist Church, where we can then figure out how to dispense with this medication, giving folk an easy way to take stuff out of their medical cabinet and then drop it off somewhere that is safe.
Thank you. One or two more questions dealing with treatment before we go on to our next segment, which is actions and resources. So hold your question, because I have one regarding early sobriety, which can be a challenge for someone who has experienced treatment or post-treatment. It's a difficult time, obviously, for an addict. The rate of relapse, I'm told, is 72 to 88% in the first 12 to 36 months. So in your opinion, what needs to happen in the best practices for family members and the patient after treatment regarding early sobriety? Anyone?
So first, as we're talking about vocabulary, I just want to address the word addict. We talk about stigma all the time, and that word holds a lot of stigma along with it. And we like to use the word substance use disorder. Okay. And that has really empowered people in saying I'm a person in long-term recovery instead of saying I'm an addict. I am a person in long-term recovery, and I can tell you from experience that early recovery is very, very difficult. But I can also tell you that wellness is very attractive, right? So one of the parts of wellness is building relationships, building back the relationships with our family and our friends and our loved ones, and it's very important that they become healthy as well. A lot of times we look at just the individual suffering and not the people surrounded by them, and how important it is for them to recover as well. And as a community coming together, talking about it, having a place to go, you know, your mother, your daughter, your son, it's very important that we feel supported by our communities and our 12-step fellowships and all pathways to recovery. Recovery is individualized. And I think a lot of times we categorize people and say, this is the path that you need to follow. There's ups and there's downs. And the support and compassion and understanding from people around us is really helpful. And I think, again, I think that we need to address it as a community. To rely on loved ones and family members for all of the support is a lot to ask for, because they're going through this along the individual as well. So in my early recovery, I can tell you, like I had mentioned before, it's the peer support. So many times we underestimate the power of person to person, the humanizing what we're going through. Everyone in this room can talk about something that they've experienced that was traumatic, and how it feels to talk to someone else who has experienced that trauma as well, and to feel understood and heard. So I think that early recovery for me, talking to peers who understand where I was coming from or who had been in the same place I had been and saw them change their lives around, was so empowering and impactful. So again, I really believe in the peer support model, and I know that it's helping individuals all across the country.
We could obviously spend hours on this. We're about to segue into the action and resources section, and we definitely want to make more comments from the audience for sure. But I just wanted to wrap up this section, kind of weave together some very important comments that people have made on the panel about bias, about stigma, about terminology, about the words that we use, not just in medicine, but in our society, in referring to someone as an addict. I'm very proud of the way at ABC News we've started to change our language. And for example, in talking about someone with autism, we don't say autistic child, but child with autism. There are exceptions to this terminology. I think if you're the person suffering from it and you want to call yourself a diabetic or an addict, that's your prerogative, but we don't say a cancerous person. We say a person with cancer. And I think when we talk about bias and stigma, we also have to remember that mental illness is stigmatized in this country, and there is a bias of not just the medical profession, but our society in addressing someone suffering from mental illness. And we have a massive problem with obesity and bias and stigma in this country. So we can't just talk about one bias and neglect the others. I think conversations like this are so impactful because they make us all aware of what are our biases and what language we're using, and that the words do matter. So with that, Rick, I know you want to transition us to action and resources.
Okay. That was a pretty good segment on treatment, though. What do you guys think, right? Thank you, panelists. Our third segment has to do with action and resources and what's being done to fight the crisis. It's no longer being left up to families to fend for themselves. Changes are underway within government and the healthcare community to change how people approach and help those who are suffering. WABC's Anthony Johnson shows us one such program. Take a look.
When a patient has signs of a drug addiction, this team of treatment specialists focuses on turning that person's life around.
Everyone's window to recovery opens and closes 100 times a day. Our job as a peer recovery specialist is to find that window when it's open and prop our arm in there to keep it open.
The team, made up of mostly recovering addicts, works around the clock to make sure that a person with an opioid addiction problem knows they have help.
Recovery can't take place without community. That's the missing piece. A sense of community, a sense of belonging.
The Robert Wood Johnson Barnabas Institute for Prevention and Recovery began in 2016 with a small staff, which has now grown to over 200. treating some 18,000 patients in the last year struggling with opioid dependency.
All they have to say is, yes, I want help, and we will hold their hand and support them through that entire process, whatever that is.
Patients that have received a dose of Narcan are easy to identify in the hospital, and so are those who are suffering an overdose. But the team works with doctors and nurses to identify patients who won't admit they have a drug problem.
We follow them. So when someone leaves the hospital, we do at the very least 8 weeks of, I call it, lovingly stalking them. So now someone is calling them. Someone really cares.
In Eatontown, New Jersey, Anthony Johnson, Channel 7 Eyewitness News.
Thank you, Anthony. So we talked about treatment, but we didn't necessarily touch upon the financial toll and the cost of it. In fact, the average cost of treatment is steep, and for medication-assisted treatment, the average cost runs from $6,000 to more than $14,000 a year. But that's just a small portion of the total cost of the crisis, obviously. Lost productivity, criminal justice treatment for overdose and other infectious diseases. They all contribute to the overall toll, which is estimated at more than $75 billion in the U.S. So we've received a lot of questions apparently online about insurance coverage. So my question to the panelists, whoever wants to take this, what types of treatment are covered by insurance, and is anything being done to expand that coverage? Anyone?
So I think this question's for me. So first, let me say that this is the struggle that families face. But sort of regardless of your politics, one of the overlooked things in the Affordable Care Act was it was the first time ever that we said mental health and substance use disorder has to be covered in health insurance products sold in the individual market, sold in the small group market. We've never said that before nationally, and that is the case now. So we have changed the conversation. In New Jersey, we went further by saying that inpatient and outpatient treatment had to be covered, and some other specific things had to be covered through private market insurance. In the Medicaid program, we cover all medications that are covered by medication-assisted treatment without copay, without deductible, without prior authorization. And we cover 1.7 million people in New Jersey on Medicaid, not quite, but close to 1.5 people. I mean, 1 out of every 5 people in the state. And we have added 500,000 people to Medicaid because of Medicaid expansion, and tens of thousands of those people are getting substance use disorder treatment because of Medicaid expansion. So there's still work to do. If you work for a large employer who has employees in multiple states, you fall outside of the scope of what is covered by New Jersey insurance law, and so you may not be protected by some of those things, and so there's much more work to do. But where we can in New Jersey, thanks to the legislature and the work that we're doing, we are trying to put as many protections in place as possible.
Miguel, do we have another question in the audience? I think right over there. Okay. I feel like Phil Donahue.
Hi, this is unrelated to treatment, but we talked a lot about family. What do you do when there is a parental intervention plan and the husband is not on the same page as the wife? The mothers generally tend to be a little bit more nurturing and recognizing the problem, and the father might be in denial. Or it may be father that's got that ego going on and just doesn't want to agree with what the mother's doing in terms of a plan.
Right.
Families when they're in crisis, that they all can't get along.
It's extremely common, and the scenario you set up is very often the typical scenario about what to do, and it's that both family members, because you also see it with siblings. You see it with other family members, get on the same page before anything's done, and compromise and learn how to compromise, because what individuals who are struggling will use that and manipulate the situation, because they're trying to figure out a way, because it's overwhelming to be confronted by family members. So the number one thing we do at the Partnership Center, what we do is we have resources for family members to help communicate within the family A lot of what we do on our national helpline is help family members communicate outside of not even with the individual. We focus on self-care, we focus on communication, and once you have a unified front, even if you don't always agree on everything, then you could start the change process with your loved one struggling.
The notion of third-party mediation, third-party interveners, faith communities can be sometimes, many times, a resource that if you are a person of faith, could we involve, right? If there's a discrepancy between husband, wife, boyfriend, girlfriend, whomever, can we involve a third party? Would you at least agree to bringing in rabbi, pastor, imam, somebody, but even if it's not a religious leader, right? A third-party intervener, mediator, is so important to help resolve family dynamics and family challenges. So I would hope that the person would at least be involved in bringing someone in, or at least going to a third-party mediator.
The most common question that I get from parents who may disagree about the plan is the issue of tough love. What do you think about tough love? Where do we go with the tough love? And my recommendation for that is threefold. Promote anything that goes towards recovery. Drive the child to an athletic activity or to a meeting or whatever it is. Do not support anything that goes against recovery, primarily having to do with money. And third, get some help yourself. It was said before, get some support for you two, independent of the child. Quite likely you may have other children as well that they may need your attention. Take care of yourself.
And may I quickly add to that? By trade, I'm a licensed professional counselor, licensed clinical alcohol and drug counselor. One of the things in helping a family is, one, help to break the collusion. Oftentimes, it's education that helps to understand that we're not against anybody in particular in the family, but we're trying to do everything to go against the disease itself, because that's the enemy of the family. That's the thing that's driving everyone apart. But as soon as people start circling the wagons and firing inward, that's when things go haywire. But our job, my job as a professional, is to say, well, you can have it your way, but then what? What do you stand to lose in that situation, and what do you stand to gain by trying something absolutely different? You can be absolutely right, but you're going to lose the person that you care about. So let's try something totally different. Your way that you've been trying it before hasn't quite worked out. Let's try and set those things and those assumptions to the side and do something completely different. And every family is totally different with so many different dynamics. But the idea ultimately is just to break the collusion with the idea of the disease being the focal point, the thing that's sucking the energy out of the home.
So I kind of want to change the topic just a little bit. And as we have all seen in the last couple of weeks, couple of months, pharmaceutical companies have been in the headlines. Purdue Pharma, Johnson & Johnson, both of them paying hundreds, millions of dollars, tens of millions of dollars, billions of dollars to states to try to settle lawsuits. And I want to open up this to everyone here. What is it that you would like to see done with this money? Obviously, it is a lot of money, not clearly enough to win this war, to beat this epidemic. But what is it that you would like to see done with this money to help? What would you like to see for these companies, these families that are involved in these companies, in terms of public responsibility and even criminal liability? And how do you think it would change what it is, this national crisis?
I think the first thing that we need desperately is beds. Because it's no good for me to talk to a young person and say, I'll get you into recovery. He agrees to recovery, and I got to tell him to come back in a week. That just not do it. And all the blame is on pharmaceuticals, which it should be, but there was collusion between the doctors and the pharmacies. There was a doctor in West Virginia at a very small town who had 3,000 patients. I think the light should have come on to either the pharmacies or the pharmaceuticals, because they were providing the pills. So I think that the money should be done initially for beds and then through education. I think education is the key. I think if we educate early, and right now, I think high schoolers are on their way. We need to go younger than that. We need to go to, 8th grade, 6th grade, and try to get these, because we've tried this in the past, but it just hasn't done what we wanted it to do. And the other one thing is that we don't smoke in a restaurant because the people who didn't smoke were fed up. This is what we need to get on board. We need to get the people who are not affected, who has not touched their families, to join the fight, because they're the ones that's going to push us over the top. So I think it's obvious that we need everybody in that same circle, and hopefully we'll get there.
The last epidemic we had where millions, perhaps billions of dollars was appropriated was the HIV/AIDS epidemic. And it worked. It was successful. We need money not only for research, but definitely for treatment. We need money to provide Narcan for as many people that want Narcan, whether they can pay for it or not. We need money to continue expanding substance use disorder centers, which give all the wraparound services that we've talked about on the panel. We have over 300 licensed SUDs right now in New Jersey, but we need more. We need more harm reduction centers. We have not talked about that. Not everyone is ready to enter into a program, but they need a welcoming, non-judgmental place to be brought to care, to be given the clean syringes, the sterile syringes, to be tested for HIV, Hep C, and STDs, to get pregnancy counseling, prenatal counseling. There are so many services at our harm reduction centers. We have 7 up and running right now in New Jersey. We need more. So do we need money? Yes, we do. And it should go directly as close as we can to the people who need it the most. And that they are the people that are suffering substance use disorder.
Thank you. Miguel, is there another question that in our audience?
Hello, Tom Ed's here. Aaron, very good job, Dr. Lavonis. There's a lot of talk here about stigma, and actually after you even said the stigma, the thing came on and said we got a group of addicts in here. And I'm like, no, these are people who may have had an addiction, or like you said, a person in recovery, but it's so ingrained that we look at people as addicts. And I'm just going to give you an example. I went to the emergency room. I'm on dialysis for like 6 years. I'm having a lot of problems from injuries in my back and my neck, and sitting in that chair for 4 hours, I was getting a lot of pain in my neck and shoulders. So one night it got unbearable. I can't sleep. I go to the ER, and I got looked at as drug seeking. And I'm like, I wanted to yell out, lady, I'm in recovery for 30 years. This is not the place where I would go to score. The woman never examined me. And she goes, I'll tell you what, I'm going to give you 1 Percocet, and I don't want you to come back here. And I was like, keep your Percocet, adios. The next day, the pain got so bad, I went to a chiropractor. And when I took my shirt off, he goes, you know what? You got muscle atrophy all in your neck, in your shoulder, and your lower back. It turned out I had a neurological problem that needed surgery. If somebody would have just took the time to give me an assessment, instead of looking at me as he's a drug seeker, I don't know how I fit that profile. I didn't say anything like, can I have some drugs, ma'am? You know, I thought I cleaned up my act enough where people don't pick it up anymore. Now, the other thing I just want to address with treatment. There is a big gap in treatment, and there's also a big gap in quality treatment. Right. Now, I'm a big fan of motivational interviewing. Most of you guys on the panel know that. And I'm also a big fan of this model called CRAFT, and it's called Community Reinforcement and Family Treatment. And it goes a good way in prevention, and it does work well in a group with a family. And these things are all vital. You know, when I sit there, and I remember the woman saying to me one time in treatment, Tom, please, don't say I'm an alcoholic. I can't be an alcoholic. And I said, I don't care what you call it. You want to take a look and see what's happening to you and what you like about this thing and what you dislike about it. And we went from there, and then we started talking about healthy drinking limits. And she goes, well, I think I'm good because I only drink 1 glass of wine a day. The glass was this big. Right, but this was the road to her going, you know what, Tom? I drink too much. And she doesn't want to be called alcoholic. And I really wish us professionals would stop labeling people. If somebody comes to that determination, I'm an alcoholic or I'm an addict, it's because it fits them. But for me to come out and say it, it's insulting. So I really wish we'd have more training for treatment providers, doctors and nurses in the emergency room, so they don't say automatically, this guy's drug seeking. Take a look, maybe I'm just looking for relief from my pain. And if I could have got that, it could have avoided a lot more problems. So thank you very much.
Thank you, Tom. Yeah, Pastor.
So the Surgeon General of California, I was born and raised in LA. The Surgeon General of California, the first, is Dr. Nadine Burke-Harris. She used to run something called the Center for Youth Wellness in Bayview Hunters Point, which is a high poverty concentrated area in the Bay, in the west side of the Bay. Nadine Burke-Harris describes in a TED Talk when she first discovered the research of ACEs and how it changed her medical practice, right? So now she says as a pediatrician, she screens for ACEs. What is the ACE score of any parent that's coming into her office so that we can figure out what are they bringing to the table and what are they likely to potentially transmit to their children. And so it has been documented that a person with an ACE score, an adverse childhood experience score of 4 or greater, is going to be 10 times more likely to commit suicide, 10 times more likely to use intravenous drugs. You know, X% this, X% that. And she says we can reduce the $7+ billion issue of trauma and childhood trauma by pre-screening and screening when the family presents itself. And so as a very personal aside, my mom at 45 overdosed on heroin in South Central LA while I was raised. Mother of 4 black boys, and the issue of race, concentrated poverty notwithstanding, I've often asked myself, what would have helped my mom? She left my last brother in the hospital, USC General, born addicted to crack, and the woman who raised my second brother, who was scalded 2/3 of his body because of mom's boyfriend, went to the hospital to get my 4th brother. I believe that if monies had been poured into the assessment by professionals at the windows in which we engage some of our families, that perhaps it could have made a difference for families and mothers like my mom. The hardest things I've had to do in my 30 years of ministry and in my 50 years of living was to stand and officiate the funeral of my mother who overdosed on crack and heroin at 45 years of age. It's fueled me to figure out how to keep other families from going down the route of my family. And in working with friends like my assemblyman who's here, Assemblyman Varelli, Anthony Varelli, and others in our community, community-based resources that are universally accessible to families before they get into crisis is what we need. And that can happen in DHS, that can happen in DOH, that can happen in DOE. How do we put resources in the community that are accessible by families before they get into crisis? It's not going to be the panacea, but at least we don't send families to 15 different doors to get the treatment they need. Let's send them to one place to get as many opportunities that they need to get the treatment that they need.
Pastor, if I may, if you could indulge me, I believe that your mom is super proud of you today. So I'd like to ask you here in the audience, how many of you think that medicinal cannabis could be an answer or an option or alternative to the opioid crisis, by a show of hands? A few of you. Anyone on the panel? Erin, do you want to take that? We're talking about medicinal marijuana, and I try not to use that term because that's really a street term. The plant is cannabis, but where do you think that fits in this picture?
And thank you so much for saying that, because the term marijuana was actually created to slander Mexicans, saying that Mexican immigrants were bringing in marijuana. So we should call it cannabis, because that's also a racist term. So this is an incredibly controversial issue. And a lot of the research studies coming out, you can trace the funding to people that are either pro-cannabis or anti-cannabis. So there's a lot of confusion, even in the medical literature, in terms of looking at epidemiologic studies, et cetera. So this is very controversial. I would always say that MAT is the baseline for an opioid use disorder, just like insulin for diabetes. But what is so fascinating is that the endocannabinoid system, we have internal cannabis system, just like we have an internal opioid system. They're actually highly linked. And so when you activate your endocannabinoid system, you also activate your endogenous opioid system. And so they've done some studies. Yasmin Hurd at Mount Sinai in New York City is the one working most on this. And she's looked at CBD, cannabidiol specifically, and that's the non-psychoactive ingredient in cannabis. But there's some studies to also show just the entire plant cannabis, that it can reduce cravings and reduce the triggering if someone sees a cue. And so someone is able to be sober longer and delay that first use and not relapse as quickly. And so it's not that cannabis is a panacea, but I think for some people it could really help with cravings. And some people are self-medicating with opioids, and so perhaps certain cannabis formulations in different ways that are not necessarily getting them high. There's lots of ways to use cannabis where you don't feel the psychoactive high. That could be very kind of medicating for the person and help them get back on a better path. And I know it's controversial, we need more research, but we can't do that research when cannabis is Schedule I, and there's tremendous evidence for medical benefit, from glaucoma to nausea and appetite in chemotherapy patients, et cetera. Cannabidiol is a great anti-inflammatory, so we need to remove cannabis from Schedule I and be able to conduct the research to take a look at all of the benefits.
Thank you, Erin.
I couldn't agree more with the research side of it. I think that this is wonderful, and we do need more research on the cannabinoids, but I would disagree on the first part that cannabis is a good idea for opioid use disorder. We do not have the data to support that. The studies are very limited, very short-lived. We have been burned before by things that look promising and engaging, and then we find out later that in the long run they are much more catastrophic than helpful. So I would not sign on the dotted line for cannabis as a treatment for opioid use disorder before we have much more data than we have now.
What about can someone, maybe Commissioner, can you comment on this? Since New Jersey has a medicinal marijuana legal state, do you see it having any role in prevention? In other words, taking patients with either acute or chronic pain and initially offering them cannabis versus an opioid?
Well, obviously, that's up to physicians at this point with medicinal cannabis. The bottom line is that there is no research, although people are reporting pretty aggressively that it is helping them with chronic pain, that it is helping them stave off urgings. And I think we need to listen to what our patients are telling us as we continue the research and understand that cannabis in and of itself is not a dangerous substance to take in. So the danger is low, the anecdotal reports are high, so, and I think we just need to listen to that and continue the research.
We just have a few more minutes left. The one area that we haven't really discussed yet is fentanyl. It has completely upended the war on drugs. Most people, from what I understand, and tell me if I'm wrong, they're not necessarily seeking fentanyl. It's just in the heroin that they are buying because it's a cheap alternative. So we've had a war on drugs, on cocaine. Does any of that from our history on how we fought those wars apply to what we are dealing with this opioid epidemic? How do you fight the war on fentanyl when you don't necessarily have users who are actively seeking fentanyl?
I think that's an excellent question. Obviously, fentanyl is coming from outside the United States, and it's my understanding that it's China or parts of the Far East. There are ways to stop that, and I think we are catching a lot coming over the border. But for a person who is going to buy heroin, he has no idea what is in that. It could be 1, 2, because it's cheaper than heroin, so they put it in to max it. We try to do different things to add ourselves and help these situations. I don't know if penalizing fentanyl would make a difference. I don't think it will. There are test kits for fentanyl. They are designed to test the heroin to see if fentanyl's in it. Is that condoning use, or is that saving lives? It's a toss-up to what it is. But carfentanil is approximately 5,000 times more powerful than an opiate is. It is so dangerous that EMTs would amount to be 2 grains of salt on their finger, and they will overdose. So these are the things that we have to learn. These are the things that have to go by and try to attack. Like I said, we do things to think that we're helping, and that's all we can do right now. I passed a law that would give a secondary labeling on opiate prescriptions. It would be in red, and it would say an opiate may cause addiction, may cause overdose. And the reason I did that was, in one of my groups, a woman came up to me and said, I see opiates in the paper every single day. I am so glad that my son is not on an opiate. I said, what's he on? He said, Percocet. So, you know, these are the things that we have to educate ourselves for. And I think that a lot of little things will make a big thing. But if you try to tackle this as head on, you will get very frustrated. So what we need to do is just tone it back a little bit, get all these pieces together, and I think we will start getting ahead of this disease.
Yeah, I mean, I think this is not going to make a lot of people happy, but what I would say is that the war on drugs has just not worked. We've been doing it for over 100 years. It's never worked. We spent over $1 trillion in the past several decades, and the addiction rate in the US is exactly the same as it was when we started the war on drugs. So we know that people are going to use substances, and when you push it to the black market, they use adulterated substances at a higher rate. And so fentanyl is the latest example of this. Moonshine is another example. Crack is another example. You end up with these kind of turbo drugs because the black market is all about making it in the quickest, fastest way possible and turning a profit and catering to the people that are trying to get the most high. So you get these extreme products. And the illicit drug industry worldwide is a $350 billion industry. The people running these cartels are making millions and millions of dollars. They're going to figure out a way to get drugs into the country. We've never had such a high supply of heroin in this country as we do right now. For my patients in Newark, it's $3 for a bag of heroin. $2.50 actually, they told me 2 for $5. So all these interdiction efforts, all this law enforcement efforts, it's literally a drop in the bucket compared to what's available, and we don't have the capacity to stop the influx. So nobody talks about this, but the actual solution, I believe, is to legalize, tax, and regulate all drugs. And so you pull it out of the black market, you remove the profit motive. And if you imagine if you could go tomorrow to the pharmacy and get legal heroin, you would know exactly what's in it and you wouldn't overdose. And so even if that's a very controversial policy, we would slash overdoses overnight if we just considered legalization and implemented it even in a pilot study. And the fact that that's not on the table and that no one's talking about it, I think shows what 100 years of prohibition does to a country, that people just think drugs are bad, let's make it illegal and put it in the black market, but it does not work. And so we have to completely reverse ourselves and look at it in a whole new way. If people are interested in this, the Global Commission on Drug Policy is a number of world leaders, former heads of state, et cetera, and they have an amazing policy document that kind of goes through all of this. And their overall kind of statement is that when you push things into the black market, you're really abdicating the responsibility of the government to regulate it, and now you're leaving something that we already think is not as safe for everyone. You're allowing people to get access to it in an even more unsafe way. So let's pull it back into the light, regulate it, and then move on from there, because we know people are going to get it either way.
I saw eyes kind of rolling back there.
Yeah. There are many problems with these arguments. Let's just remember that the very core of the current epidemic was a legal drug. It was the legal drugs that got us where they got us in, not the illegal ones. It's a prescription opioid epidemic at its very, very core. So let's remember that the biggest problems that we've had were with legal drugs, tobacco, alcohol, prescription opioids. These are the real menaces of what we see today. And it can be an argument like, the gun laws have not worked. You know, it's really terrible. We have all these gun issues. Therefore, let's legalize drugs. That's the solution. Let's legalize guns. That would be the solution to the failure of the gun laws to deliver the goods. This is not a really solid argument. It's more sensational. I think we need to really think about these matters much more carefully.
Commissioner?
Yeah, I just want to go back to your question about fentanyl. I think we're going to continue to chase the next, the Assemblyman mentioned carfentanil. We're going to continue to chase stronger and stronger drugs in the illegal market. That is why we have to build the prevention and treatment and recovery services that ensure the most resilient possible families, that we have services available when people need treatment, that we can support them in recovery. That 20 years ago, you wouldn't have a panel like this. You wouldn't have people from this cross-section talking about this issue like it's a disease. We now all talk about this issue like it's a disease, and we are committed to building the system that responds to it like it's a disease, because that's our obligation and that's what we want to do.
We have just about a minute or so left of our program, and I just wanted to open it up to any questions that may be out there that you would like to ask our panel. I think Miguel is making his way right over here.
My name is Willie Wilburn, and the question I have is, if a person is receiving treatment, I actually have two questions, and they apply for a job, and they're at a job where they're being tested, drug tested, how does this affect their ability to sustain that job?
I'll just answer that very quickly. Most drug screens are a 5-drug screen, which may or may not include methadone or buprenorphine. Those, as part of MAT, those come up with a separate test. So oftentimes I just tell the person, you could give it a try and see. They might not catch those medications on it, because if it's looking just for opiate, methadone and buprenorphine are both synthetic, and so they won't show up. If it does appear on the drug test, then you can write, you can get a letter from your provider saying that this is a prescribed medication, and it's actually part of the American Disabilities Act that you can't be discriminated against for that. So the person could just be upfront about it right in the beginning, provide the letter, and they're not allowed to discriminate against you because you're in treatment.
And the other question I had was, we find that a lot of young people between the age of 26 and 30 don't have medical coverage. They're calling up these treatment programs, and the first thing they hear is, we need money. $200 to get in, $80 to stay in the program. What is being done about that? Is there a list of places that have free treatment, or how do they?
We want to get them coverage. We want to get them coverage. That's why we expanded Medicaid, so if their incomes are below 138% of poverty, we can get them on our affordable free Medicaid coverage if they need it. Then if not, we can get them on Affordable Care Act coverage that is subsidized by the federal government, and for individuals with the lowest incomes also pays for some of their co-pays. So our goal is to get people covered. That's why the governor and Judy and I have been working so hard to make sure premiums stay low in New Jersey so that people can get affordable coverage.
And also, we had forgot to mention this is important. The Division of Mental Health and Addiction Services has a treatment directory. So if you Google New Jersey Treatment Directory, I guess you have to put substance in there now that I think about it. But if you just Google New Jersey Treatment Directory, it does come up as the first hit. And it tells you, is it inpatient, is it residential, is it outpatient, do they have MAT available? And they also say which insurances they take and whether or not they take Medicaid, and if they have state-funded spots to take people who are uncovered. And then also that 1-800-REACH-NJ number is the best number to call, because that's someone that's very familiar with that list and can walk the person through that process. But it's not easy, and our treatment system is broken. This is the problem when you introduce profit into healthcare. So we need an entire revamping of our treatment system, because it's not right that people have to go shopping around for places and charge money. It's obscene.
I know we're getting close to the end, and I would just like to say that if you're in recovery, you have to tell that story every single day. You have to tell that story to people you don't know. When you go to Wawa for coffee, you tell that story. Because if we don't have the stories of recovery, we don't have any hope. And that's what you bring to the table. That's how you're help fighting this epidemic, is by telling your story of recovery.
We probably have time for one more question. Did I see a hand? Oh, go ahead.
Yes. I have a daughter at home. I'm a recovering addict as well. I have a daughter at home. She's 38. She's bipolar schizophrenia. And by her having this, they have her on, she's a heroin addict as well. By her being like this, they have her on Suboxone, Haldol, Tramadol, and a whole bunch of other medications. But the treatment that they're giving her is, she's not getting any proper treatment. I don't think so. She's living at home with me, and I'm scared to death because she hears things, she sees things, she's talking to things that's not there. And I called and asked the people the doctors that are giving her this medicine, I told them that they need to do another assessment on her because she's living with me and I'm scared to go to sleep at night. And I don't know what resources to reach out to because she's 38, so they're saying that she's grown, that I can't, ask any questions or they won't give me any information, but she's living in my house and I have custody of her daughter. Her daughter sees her, with these behaviors, and I don't know what to do. I really don't know what to do because there's nothing out there that I can take her to because she should be she should be supervised. She should be being supervised.
Maybe I could talk to you after the panel to delve in a little deeper about where you live and what the services may be. Okay?
Well, we want to thank everyone for spending their afternoon with us to discuss such a very important issue. As we have seen, I think, here in this room, there are so many of us who are going through this, that you are not alone. We want to go ahead and thank Robert Wood Johnson University Hospital for hosting this important discussion. We want to thank WPVI for being an integral part of our partners and helping putting this on. We want to thank you all for coming out, asking your questions, and we want to thank our panel for coming and spending the afternoon offering your expertise to help people here, people who are watching at home, who are in this struggle right now. So thank you all very, very much. If you'd like any more information about resources to the crisis, you can go to abc7ny.com and 6abc.com. We have a lot of resources, links for help, links to many of the folks up here, and further resources that could help you in this. And we have posted all that information there, and you can watch this town hall again, this important discussion. And please, if you are going through this, remember you and your family are not alone. There is help out there. Thank you all again very, very much for coming out today.